So good morning, and thank you very much for that introduction, and my thanks to KSM for having me here today. And also, very happy to see all the faces that I know in the audience, and thank you for being here. I thought I'll speak a few words of depression, hopefully without depressing you too much. And to start off with, I thought it was raining when I made the presentation, when I got ready. And this was one of the things on the news that there's a depression in the Bay of Bengal, and therefore there's going to be a lot of rain. So that reminded me of my lecture, and I was wondering, what does that mean? Does that mean that the Bay of Bengal has to have antidepressants? What are your thoughts? So that really brings us to the word depression in the English language. What it means. It's really all that it means here in the Bay of Bengal is that there is a lowering of weather in the Bay of Bengal, and that's going to lead to rain. And that's all that the word depression means. It means a lowering. Okay. And that's the English word. And when we use it in everyday, conversation, you might use it just casually to say, I'm feeling really depressed, as in to feel I'm feeling it's a Monday morning, I don't want to go to work. Or if it's medical students, I don't want to come for lectures on a Monday morning, so I'm feeling really blue and depressed. That's just the mood. As doctors, we also use the word depression to mean a diagnosis, which is different from just feeling a little sad. And so English is very confusing in that we have depression used in different ways. For the rest of this next half an hour, I'm going to be talking about depression as a diagnosis. And I should also apologize if I sound a little hoarse. Let me assure you, it's not COVID, it's been tested for. Yeah. So when I say depression is a lowering, depression as a diagnosis, we're really talking about a lowering. Now, when you think about depression, you might think about, oh, the person must be feeling really sad. Yes, feeling sad, having a low mood is a part of it. But that's not all of it, and sometimes the person may not even complain of feeling sad. So, because depression is a lowering of a lot of things. Energy, feeling tired all the time, feeling a bit flat, not enjoying things, not enjoying what you used to do. So, if it's an older person, say a Sri Lankan older person who's, been depressed for a couple of months, if you ask them, are you feeling dukkaida, are you feeling sad? They might say, there is nothing for me to feel sad about. But I feel tired all the time. My body aches. If you ask them about suicidal ideas, they might say yes. But they won't say they feel sad. So I think just feeling unhappy is not depression. It's a lowering of a lot of things. And for different people, it could present in different ways, and they could articulate it in different ways. The reduction of energy, enjoyment is as important as the reduction of mood. And that's really the terrible part of it. It takes away your sort of enthusiasm to do things. Together with that, you can lowering of concentration. So when medical students or students get depressed, the first thing they will say is, I can't remember anymore, because they can't focus and they forget. There's lowering of libido, appetite, concentration, sleep, and a lot of lowering of the way we think about things. So usually on a Monday morning, you might be a little negative and have some negative thoughts. On a Friday evening with the weekend coming up, you might have a lot of positive thoughts. Life is a mixture of positive and negative. When you get depressed, it's like you get set in the negative. So your thoughts about yourself is negative, work is not going to go right, exams are not going to go right, things are going to go wrong, the country is going to be terrible, that we might think anyway, and I'll come to that in a minute. Okay, so lots of negative thoughts, pessimistic thoughts about yourself, your future, people around you. And if that gets more, then you're going towards, there's no point in living, better to have ideas, better to die, and you're going towards suicidal ideas. So it's this whole picture that we call depression. Now, at this point, you might be thinking, yesterday morning I felt like this. Monday morning I felt a bit down and negative and miserable. Does that mean that I'm depressed? how do we differentiate? Because all of us go through all these emotions all the time. We have moments of unhappiness, moments of grief, even days of unhappiness. So does that mean that we are depressed? Or do we need to treat unhappiness with antidepressants? And a very strong answer to that is no. Unhappiness is just, it's unhappiness. You're not going to medicalize it and treat it, and you should not be. So the skill is then, how do you recognize that somebody's gone beyond that to a state of clinical depression which needs further support? And that's the challenge. Part of that is your clinical skill. But a hint to look at it is looking at, if you're depressed, you tend to be stuck in that negative state through the day. So it doesn't fluctuate very much. A mild depression might, but certainly a severe depression, you're stuck in that sort of negative frame through the day, day in, day out, for days on end. And usually the diagnostic criteria will say you need to have that for more than 2 weeks. But most of the people we see, it's been weeks and months. And together with that, it gets in the way of your normal functioning. So it depends on what you do. If you're a teacher, this kind of blueness gets you down, the negativity gets you down to the point where you can't focus on your work, you stop going to work, or you miss work. If it's a student, you're not attending to your studies as usual. So it's not somebody who's anyway missed work, who's missing anyway, but it's a change of behavior, a lowering of functioning. So that it's all in combination that you make the diagnosis of depression. By the way, if there are any questions that people want to throw out to me at any point, you're very welcome. Okay. So the next question we ask is, who can develop depression? And the answer to that is, if you've got a brain, you can get it. So if there's no brain, there's no problem. But many of the psychiatric issues that we have, depression, bipolar, schizophrenia, it's almost like the price we pay for having a very advanced, developed brain and cortical functions. It's the other side of the coin. And sometimes you might think depression only happens to, young people, old people. It could hit any one of us, any time, any age, any background. It's not a respecter of people, of places, or social classes. And when I say any age, I mean any age. But the mean age of onset, if you want to know, is probably in the early 20s. Late 20s. About 28 is the mean age of onset. That's a time where people are really, active and productive. So it's really a bad time to get hit by an illness like this. Sorry about that. Yeah. So when you look at etiology, I'll just touch on it. So the next question people ask is, why do people get depressed? So there is no one answer. It's like many other non-communicable diseases. If you take diabetes, for example, I can see Dr. Anthony Pillay in the audience, and I shouldn't be talking about diabetes, but I just thought of it as an example, because you might have, say, 2 siblings with a family history of diabetes. One sibling gets diabetes, the brother gets, a sister doesn't. So the brother might ask you, why did I get it? Why didn't my sister get it? But then you might find there's a family history, and also the brother has a sedentary lifestyle, a sweet tooth, the sister doesn't. So it's a mixture of genetic factors, a bit of luck, your genetic lottery, also environmental factors that can contribute, multifactorial. So some of the common things are childhood trauma is a predisposer. But again, just because you have a genetic, family history and childhood trauma, you may never get depressed. It may never happen to you. But then on top of that, you might have other stressors, loss events. At a certain point, when one thing is on top of the other and you jump a certain threshold, you might develop the phenomenology of depression. Or else you might not. You might develop it without a family history. Okay. So, but these are, evidence will show us that these are some of the factors. And when it comes to stressors, childhood issues as well as adult loss events are important. And I talked again about the brain being an important part of depression as a disorder. What we know is that there are certain neurochemical changes in the brain with depression. These are some of the neurotransmitters we talk about, particularly serotonin and noradrenaline. There's a lot of new work on glutamate as well in depression. And this is probably just the tip of the iceberg, because we are talking about these are neurotransmitters in the CSF that we are looking at. But depression is associated with lots of changes within the neuronal cell bodies. So when our antidepressants work, what we know is they take time to work, because it's not just changing neurotransmitter levels. You're also changing a flow, causing a flow of changes in the neuronal cell bodies, particularly BDNF, brain-derived neurotrophic factor, and you get actually neurogenesis, or rather increased synapses, increase of the neuronal connectivity if you're treating depression. And the reverse is, if you have somebody who has chronically untreated depression, you can have reduction in cortical volumes, brain cortical volumes. So hippocampal atrophy. That's with chronic severe depression that is not treated. So we don't understand the whole of why this happens, because obviously the brain is the last frontier. It's the most complicated organ that we have. And we know we don't really understand the subtleties of it. But there is a very biological basis to this as well. Okay. Right. So I just thought I'll put this question to you before I move on. So because even when somebody gets depressed and they come to us, I've had people tell me, "Doctor, I must be really weak to become depressed because of this." So would you agree with that? Are you in some way weaker than somebody else, or morally weak? Or let me put another example. If you have somebody with an older lady with a bit of osteoporosis, she slips and falls on the KSM stairs and breaks her leg. And then we have treat the fracture and manage it. Would you blame her for fracturing her leg? Would you call her weak for fracturing her leg? Or would you see it as an illness? And you say, okay, there's a fracture, it needs to be treated, she needs time to get better. So we see that very clearly as an illness, but when it comes to depression, it's more difficult. And why do you think it's difficult to identify depression as a disorder? I think part of the problem is we can't see it from outside. There's no broken leg to see. You can't do an X-ray and see it. So it's something inside that's happening. The person experiencing it knows there's something different in me. Okay, but sometimes they themselves also might blame themselves. I should be stronger than this. It's my fault that I'm depressed. And looking at it from outside also, you might feel that way. So I strongly disagree with the statement that only weak people get depressed. I think it's anybody with a brain who has a functioning brain can experiencing it, depending on the situation and what you bring with you. Okay, but I'll leave you to decide on that. So to wake you up, I thought I'll go to a couple of case scenarios. Okay. Now this is something we see a lot around the O-level times, O-level, A-level times. 16-year-old boy dragged in by his mother, okay, because she's worried. He has been withdrawn for a year. He's not talking much with the family, getting irritable. Zoom classes send him to sleep, okay. And I'm sure we're all familiar with this scenario, but the mother notices a difference, a change. He's more irritable, he's not talking to them, he's more withdrawn, his school performance is dropping. And in the background, you see it's his O-level year. There are little issues at home, parental issues, parental conflict, a bit serious. And he's a quiet, sensitive sort of chap. So he's a quiet sort of, a bit of a warrior. Can you see a picture here? Now, could this be depression is the question. Can you diagnose depression from this history? Is it enough to diagnose? Now, if you remember the criteria I said earlier, I don't think this is enough here to diagnose a depression. But would you suspect it? That's what I want you to think about. Would you include this in your differential diagnosis? And if when you talk to the boy more, you may find, so really depression is a clinical diagnosis. You would need to talk to him, interview him, look for the other features of depression that I talked about. Okay, exclude any other possibilities. But unless you think about depression as a differential, you won't go for it. Okay. But there are, in this case history, there are a lot of red flags suggesting depression. So the message there is you need to talk to him and assess him further. And if it is adolescent depression, certainly there is treatment available. The first line treatment would be one of our mildest antidepressants, selective serotonin reuptake inhibitors. Fluoxetine is the one. But remember, it's never medication alone. For a young person, often if there is a depression, the important parts of that young person's world is the family, school, relationships. So you would need, so what we would do is explore what are the other stresses going on in those worlds around this young person. And depending on that, addressing those issues. It could be a relationship issue, it could be, in this boy's case, it could be the family and the parental conflict and being stuck at home with the parental conflict for 2 years in COVID and not meeting his friends and not getting out of the house. So then part of the management, or the other than your medication or with your medication, would be looking at addressing those. So management is also holistic, not just a pill, addressing those stresses as well. This is, I thought I'd put this up because this is something we get referred from the obstetric wards quite often. A woman antenatal 3 months, no, postnatal, sorry, 3 months, and the child, the baby is slightly underweight. And the public health midwife has noticed that the woman is, not very interested in feeding the baby. And when you tell her to feed the baby, she gets annoyed. And this is something we hear of. The PHM or the nurse gets upset. This mother is not interested in looking after this baby. Must be a bad mother. How can she do something like that? And it's very easy, unless, right here you'll be thinking of depression, but when you're somewhere else in a busy clinic, lots of people telling you all sorts of things, it's very easy to think, okay, something wrong with her, that she's a bad mother for not feeding that baby. Again, and when you talk, but if you think of the differential diagnosis of depression, again, you don't need a CT scan or any investigations, you just need to make a clinical diagnosis. And I just thought I'd quote something that I remember one depressed mother told me. She said she doesn't have a problem. The baby is okay. It was a wanted pregnancy. The husband is supportive. Otherwise, we blame the poor man. So it's not his fault. But she said, I don't feel anything. I wanted this baby, but I don't feel anything for the baby now. I don't feel love. I don't feel enthusiasm. Okay. I just feel flat. So that's that lack of enjoyment, lack of enthusiasm. It's a terrible feeling when it happens. And she felt guilty about it. I must be really bad for a bad mother for feeling this way. And sometimes if that were to go undetected, if it went further, then you might move on to a couple of months later, she might be having suicidal ideas, suicidal attempts. Okay? And that's what you call postpartum depression. So again, you need to think about it, and then, if suspected, the diagnosis is relatively straightforward. If you're not sure, refer. And postpartum depression is not unusual. It's about 10 to 20% of deliveries. Some of it will start in the antepartum period, about 1/3. And if it's not detected, it's a tragedy because it can be treated and it responds quite well to treatment. And if it's not treated, of course, we know it affects the woman, the child, the family. And again, people worry about antidepressants in pregnancy and lactation. Ideally, you don't want a pregnant or a lactating woman to have any medication, ideally. But you have to weigh up the pros and cons. Untreated depression itself can have effects on the fetus. There are studies to show that untreated depression can cause growth retardation. So if you have to, you have to. And SSRIs are the safest, both for breastfeeding and pregnancy. Any questions to throw out at me at this point? I hope I haven't depressed you unduly yet. This is post-stroke depression. I thought I'd flag it because I'm sure this audience sees it more than I do. The prevalence is about 30 to 40%. And again, think about why somebody after a stroke might become depressed. The multifactoriality of it. On one hand, if it's a, say, a right-sided left brain stroke, you might have a massive loss of function, loss of independence, terrible thing to happen to any one of us. So there's a massive loss event there. There is also a brain injury because it's a stroke. And we know that if it's left frontal strokes, for example, are more prone to develop depression. So there's a biological impact there as well. And if the post-stroke depression is not treated, it's more likely to have higher morbidity, mortality, and the person is just not going to cooperate with the rehabilitation. And the way you might detect it is, 4 months after the stroke, you expect the person to be, moving around more, walking more, but they're not. Compared to the physical injury, the activity level is less than what you expect. If you see that, think about could there be a depression here? When you're treating with SSRIs, one thing we are careful about in older age is it can cause lowering of sodium as a side effect. I mean, SSRIs are very mild. Most side effects are gastrointestinal. But in old age, you can get low sodium, which can cause confusion. So generally, we keep an eye on that. Depression and diabetes, there is definitely a correlation. I don't think we quite understand why, but the prevalence of depression is greater in people with diabetes and vice versa. It also interferes with the management. So if you get depression and diabetes together, both managements are affected. So again, it might present in any way. Any of the case, the way the symptoms that I described before, lethargy, tiredness, unexplained somatic symptoms, just irritability. And I didn't mention earlier, for male depression, it often goes with alcohol misuse. So you might not see the depression, but you might see somebody with alcohol misuse. Just think about the possibility of depression. And if you're treating somebody with depression and diabetes, again, SSRIs are recommended just because things like tricyclic antidepressants cause weight gain and might impair the glucose tolerance. These are some of the other treatment options for depression that I haven't mentioned. The venlafaxine is a second-line antidepressant. We don't routinely use it as first line. It's more powerful than SSRIs. It also has more side effects. It's more complicated to use. So in primary care, first episode I would say in primary care depression, mild to moderate, go with SSRIs. Okay, escitalopram, citalopram, fluoxetine. The side effects are mostly gastrointestinal. Watch for sodium lowering in old age. And the SSRI other side effect which I didn't mention, it can cause some sexual dysfunction in younger people. So if you find somebody refusing to take it without a reason, that may be a possibility you need to think about. Okay. Tricyclics are the good old, old class. Yeah. So they've been there for years. They're very good. They also cause side effects like sedation, dry mouth, weight gain. So they are generally second line. Severe depression responds well to ECT. Transcranial magnetic simulation is something a bit similar to ECT. It's a newer treatment modality, not so effective, but less invasive. So there's an electric coil that they use to create a magnetic zone around your head rather than having an invasive current. These are some of the... I just thought I'd mention ketamine because that's a newer medication that's coming into the field. It's not guideline recommended at the moment. Now, anesthetist, if there are anybody doing anesthesia here, you might be standing up and thinking, what is this? Ketamine is our drug. It's true, ketamine is an anesthetic drug. But it's also a glutamate receptor blocker in the brain. And remember, I talked about glutamate being part of the picture of depression. So what they're finding now is very low sub-anesthetic level doses of ketamine, usually IV or intranasally, causes a rapid improvement in depression. Within a few hours or days, you see a change. Unfortunately, it's also very short-lasting. So at the moment, it's still in a trial stage. If anybody wants to do research in Sri Lanka, it's an area we haven't looked at. Okay, we haven't done, there are trials overseas looking at ketamine for depression. And it's, like I said, subanesthetic doses, so you don't get the dissociative symptoms that you usually do, and the anesthetic symptoms. Now, I was talking about all the new treatment. Don't forget, in any particularly mild, moderate depression, just common sense things. Okay, I put it up there with a picture so that it might stick in your mind. Okay, I know exercise is something I talk to about people. I should be doing it more myself. Why am I talking about exercise in depression? Has anybody, got into the routine of doing about half an hour's exercise, work up a little sweat, then have a shower? Do you feel a little better or do you feel terrible? You feel a little better, and that's the endorphins. Okay. And so when people, particularly mild, moderate depression, including a little bit of exercise in your day is often very useful to lift the mood. Have a bit of a routine, good sleep hygiene, so the opposite of breaking rest. Having good amount of sleep and the relaxation, recreation, depending on what suits you. Okay. A lot of people ask me about meditation in depression. What are your thoughts about this? Would meditation be helpful, harmful? There's work, yeah. So there's works. So meditation is a complicated thing, I think. I don't know a lot about it. I'm not a specialist, but what I know is if you're doing a lot of deep meditation, okay, there is a focus on negativity. And I mean, it wasn't taught that way, but when you're depressed, anyway, you're very negative. And when you're meditating, you might then tend to focus a lot on negative things. Not in the way that it was preached, but you might not be able to take the middle path. I don't know whether I'm making myself clear. So rather than going the middle path and doing it as it was supposed to be done, when people are depressed and start meditating, they get really, really negative, thinking of a lot of negative things, going down in a spiral. And that's not what was intended by meditation. So that is what you need to be careful of. So that's why I often say don't start with that at the beginning. Don't immediately go and start meditating just because you're feeling depressed. Okay. But distractions, recreation, anything that suits you, certainly. Okay. Questions on that? Comments on that? So this is just, I put it up there. So again, because you might see somebody who has been treated for depression, now looks quite well, about 2 months later, and then comes and asks you, can I stop my medication? I feel fine. And that's a very natural human reaction. Because if you look at, is there anybody here who's finished a course of antibiotics? I can see microbiologists also in the audience. Finished a course of antibiotics 3 times a day, 5 days. When do you stop the treatment? Is it at the height of your symptoms or when your symptoms get better? So when they get better, no? And all of us are human beings. Yeah, I do it. So when the person gets better, the inclination is stop. So work with the patient, explain why it's needed. Because evidence definitely shows if it's one episode of depression, in the first 1 year, the rate of relapse is high. Cover that, and if you're well after that, your rate of relapse is much less. So you can stop it after that. If it's recurrent depression, better to take it for longer, because again, the risk of it coming back. And again, apologies to the physicians and endocrinologists. I often use the analogy of diabetes and hypertension here. And people have the concept of taking medication, hypertension or diabetes for a long time. It's a bit like that. It can come back. Slower than diabetes would get worse, I think. Yeah. Right. I thought I'd finish with a few words on the current situation at the moment and how is that affecting depression and anxiety. This is Sri Lanka, and I think this is us worrying about, not us, but all of us are facing a lot of stresses at the moment, and the whole country is facing a lot of economic issues. Is that going to affect rates of depression, suicide? What do we know? We don't have data on depression rates for Sri Lanka. There is data on rates of depression worldwide during COVID. And the international data suggests that rates of depression and anxiety were higher during COVID. This is international work, not from Sri Lanka. What's happening with us now and what will happen with us if restrictions continue is something we might need to think about. And the next, and also whether this will affect suicide rates. Sorry, I seem to have. So this is actually work that we have done. We looked at suicide rates in Sri Lanka from 2016 to 2021. The data was from the police. And you can see are you happy with that or not so happy? I'm quite pleased with it because this is through the COVID period. We expected some people who were worried thought the suicide rates would go up. Actually, it didn't. Our suicide rates have stayed constant. And we see this in the rest of the world as well. Most countries are reporting no increase in suicide rates so far, which is a good thing. We don't quite know why, but we're happy with that. And this is just looking at Sri Lankan suicide rates by methods. The green line on top is suicide by hanging. The purple line on the bottom is suicide by pesticide injection. So overall, our suicide rates are remaining constant, but our pesticide suicide rates are dropping partly because pesticides are not available. Our hanging rates are going up slightly, but not as much as they used to do with pesticides. Okay, so overall we are stable. We also looked at, this is our work from the Peradeniya Hospital Toxicology Unit. We looked at the number because we see lots of people in Sri Lanka attempting self-harm, attempting overdoses, Panadol overdoses and coming to hospital. I'm sure they come here too. So we looked at the number of hospital admissions for attempted self-poisoning from 2019 to 2021. And that's again through the COVID period. And can you see the red line, the red kadaira? That shows you that the admission rates to hospital with time, you can see it's going down. So we're actually seeing a drop in self-harm admissions. You can argue why that is. And during lockdowns, there was a significant drop. That could be because people couldn't come to hospital and people didn't have access to medications. But overall, we are also seeing a drop. Maybe people are not coming to hospital, or they are going to smaller local hospitals and not coming to Peradeniya, or there's a genuine drop. We don't know what. Okay, but it's interesting, fascinating to see, I think. So the next question is, where do we go from here? Okay, so our suicide rates are constant. Self-harm seems okay, but we are facing a lot of stresses in Sri Lanka at the moment, particularly economic stresses. So I think we need to keep an eye on the situation, and I am not sure what has happened to my slide at this point. Well, we need to watch the situation, and I think my take-home message is keep depression as your differential diagnosis. It may, in situations where I described, if you remember, it may not always be depression, but unless you keep it as a differential diagnosis and think about it, you will miss it. And you might be the only person who gets a chance to assess for depression and manage this eminently treatable condition. And I thought I'll just leave with a few true or false questions. These are things that people ask us when we start treatment. Antidepressants are addictive. Would you agree? Hopefully everybody will say no to that. They are not addictive in any way. Benzodiazepines are. Antidepressants are not. And the effect of antidepressants wear off with time. This also people worry about. A couple of months down, they say that doesn't happen. Antidepressants actually work slowly, but they continue to work. Okay, so continuing it is not harmful. Some people think if I start treatment for depression, I can never get off this medication. Again, false. Okay, with the first episode of depression, you treat for about 6-9 months and stop. Occasionally, there may be situations where you have recurrent depression where you have long-term treatment, but that depends on the patient. Antidepressants take time to work. That's actually true because, like I said, it takes about a week or 2 weeks to kick in, and that's again because of the very complex changes in the brain that we talked about that are happening. Everybody with depression needs CBT, not at all. It depends on the situation, and antidepressants should not be used in pregnancy as a blanket statement is incorrect. Okay, it depends very much on the situation, and remember, untreated depression in pregnancy itself affects the fetus. So you need to weigh up the pros and cons and decide, does this person need treatment? How am I going to treat? All right. And I think my time is roundabout correct as well. So I'm going to stop there. Thank you very much again to the KSM for giving me this opportunity. I hope this was useful, and I'll be happy to hear any questions or comments.
Professor Thilini, I'll ask a small question from you. It's regarding one thing is about meditation. In meditation, I mean, when someone does meditation, it depending on the person who teaches, and everything is depending how we grasp things, depending on our personality and education level, and many things matter. So we, as a general rule, sometimes this may be affecting if everyone tries to, meditating, as you mentioned, in negativity is the main thing, so it can affect. But same time, if they are educated enough to understand, education is not the what I mean by the degree or anything, but the general education level. So they might be in a different level of. And what I think is how they perceive things in big picture may different.
So I'm not talking in any way about meditation in general, because in general it's a very personal thing, and that's very different. I am only talking about meditation when somebody is clinically depressed. So what happens when you're depressed is you're sort of stuck in a negative place, and that's what I meant by saying it can affect any one of us. I can get depressed, and no matter how educated or intelligent I am, when I am depressed, I see everything. It's like putting on a pair of dark glasses, and I see things through that view. You know, I'm stuck. Everything is negative. And even if I approach the meditation, which I would normally do in a different way, I might approach that also in a very negative way. And I might not do it in a way that's beneficial to me, and may not even be in the way that's preached or advised. That's the risk. And I might not be able to judge that in that time. Retrospectively, when I'm better, I might say, what did I do? But that's the danger that I see. So
Thank you. There's another question. This is regarding, because in the current economic situation, especially the doctors, like there are many worries about our children, education, spending, many things. So, do you think it's, as a community we are depressed, or I mean, not the doctor community, as a Sri Lankan, we all face when it comes to economic crisis, many things matter. So then, in this kind of situation, what is your role in attending to that? What can people do about it? I mean, other than changing systems, changing whatever that we think is possible. But I'm in the
ideally, you want an economic solution, no? You want the policy changes. But well, to answer the first question, I don't think as a community we are depressed. In fact, I'm amazed at the resilience of many people and the resilience of the community. I mean, for example, during the time when we were all walking to work, I would walk past long queues of vehicles, including three-wheeler queues. And once when I was walking past, I saw the drivers out on the road playing cricket. This is in the height of the problems, no petrol, people in queues walking. So that's resilience. And that's amazing. And I think as Sri Lankans, we have a lot of resilience, and we shouldn't underestimate that. And uh, perhaps what we should, I mean, it's difficult times now and difficult times ahead for whoever, for all of us. Play to our strengths, maybe. Okay. So as a country as well, which is maybe that's why we are having the cricket matches at the moment. And I heard India got thrashed. So what better treatment, except Dr. Gihan is not interested in cricket, but yeah. But so as a community playing to our strengths, and on an individual level, um, it's sometimes what I talk about, although not meditation, learning to live in the moment. So focusing on the moment is, I think, important, because otherwise we tend to get into a spiral of what will happen tomorrow, what will happen next year, will the schools reopen, will they be able to do this, that? And true, we have to worry about it, but if it constant worry doesn't change the outcome. So then bringing yourself back to the present, appreciating what we have in the moment is often very useful. It's difficult. And like I said, exercise, sleep, hygiene, recreation, whatever that works for you personally. So what makes me feel better might not work for you. So identifying what helps each one of us. Not alcohol probably, or not too much alcohol probably, because that sometimes makes the thing better temporarily versus the situation in the long run. Okay. So, okay. So everything in moderation. We're talking about meditation here. So middle path for alcohol as well. Yeah. I was not intending this for any person in particular.
But we know.
But Mr. Duas.
So you want to.
I have a question now. This depression you are talking about is not a psychotic disorder, right? Not like bipolar.
So depression, if
You
it's
don't get hallucination and stuff.
most people with depression don't. Majority of people won't. Most of us. There is some small group, a minority, who will have very severe depression with psychotic symptoms. They might have delusions, hallucinations, and so for the medical students, for example, they might see more of them because this is the biased sample that will get admitted to hospital. But most people with depression are in the community, they come into clinics or they're not getting treated at all. Okay. So you can get psychotic symptoms, but it's not in the majority.
Is it curable, this kind of depression?
All kinds are.
All kinds of.
If you detect it, it's just like any other disorder, hypertension, diabetes. No, like say, it's more like a non-communicable disease. So you have, for example, diabetes. Apologies, I'm always using this example. Where you will get a majority of people who respond well to treatment, who stay well on treatment, who are functioning. So you see that in diabetes. But there will be also a group that don't respond, need insulin. Some people who are recurrently having hyperglycemic episodes. So just like that, even with depression, there will be a group that are less responsive, might need more medication, might have more severe symptoms. But that's one part of it. The majority, so it's well worth identifying and addressing. So,
Thank you very much. Very, as usual, enthusiastic wellness lecture. I have a question. Are these depressed people there? So non-depressive people, don't they perceive the problem better than the depressing people? No, say, for example, the country situation.
Yeah.
Now you said the people who are playing cricket.
yes.
So they have taken that into that, not only resilient, they have another alternative way of thinking. And they approach the problem in a different way. Rather than, revolving around the problem, they solve the problem, okay, they fall asleep, and then tomorrow morning think about the problem again, that sort of thing. So there are people like that, differently. So do they, are these people who are depressed, don't know how to perceive a problem or solve a problem and analyze a problem? Are these the people who are getting depressed?
Like I said, depression can happen. It can happen to any one of us. And it's not necessarily because, so the person who was playing cricket and resilient in that situation, so say in that particular situation, they cope really well. It might be a different situation where they're very close to their father and their father suddenly dies. And that's their button and their vulnerability. And they also have, say, a family history, they're a bit sensitive. So that hits them, but this doesn't hit them. So I don't think it's an us and them thing. It's just all of us. It's not that the person who gets depressed is a separate category or a separate. It's all of us at some point in time. I don't know whether that made sense. Sir.
Yeah, it does make sense. Some people overtly do certain things, such as getting into religion and do exercise. Some people when they're depressed, don't they do over exercising and over religious?
I have yet to see over exercising. Oh, I have not seen over exercising in depression. But I have seen people who get very stuck in religion with depression. That not to say that everybody religious is depressed. It doesn't go the other way. Yeah. There is, so, but when people get depressed, I'm not looking at anybody here. Um, but when people get depressed, I mean, so you might cope in different ways. For one person, it might be taking more alcohol. For another person, it might be getting really irritable and withdrawal. Okay, and for some, it might be becoming more religious. But I think it's not in the way that religion was intended, because you get really negative, you're really stuck in it, and you're looking for an escape from your misery rather than true philosophical religious principles. And so sometimes you have people who take up robes when they are depressed. Again, not everybody who does that is depressed, but it can certainly happen. Yeah.
Thilini,
Yes. Hi.
listening to you talk about depression, I was actually feeling manic within me.
So glad.
You presented it so well. So thank you so much. I've got two questions. First is we come across patients with diabetes. When you talk to them, you feel that they are depressed. So there are no suicidal thoughts.
Yeah.
Low energy, they don't comply with the medication, and they look a bit frustrated. But when you talk to them and tell them that I'm going to refer you to a psychiatrist, they're very reluctant to go and see a psychiatrist.
Yeah.
So in that case scenario, is it possible for us to start a small dose of escitalopram or something like that? And what would you suggest?
Yeah. That's often a challenge that we face. There's a lot of stigma around seeking psychiatric help or coming to a clinic. If you feel reasonably so talk to the person, and if you feel reasonably confident that depression, at least there's a mild, moderate depression here, um, it's worth treating. Caution when it's diabetes is if the diabetes is also poorly controlled, then the physical symptoms can also be due to that. But I'm sure you're looking after that, so you don't need that. So if the treatment, you could look at pharmacological, and if you're starting, it would definitely be an SSRI, citalopram, fluoxetine, sertraline, and maybe a quick query about whether there are any stressors that are maintaining this. So, because sometimes there may be underlying, say, if it's a woman coming from a household with domestic violence, unless that is addressed, no matter how much she may be depressed also, but no matter how much SSRI we give her, the stressor is there. So sometimes, particularly for mild and moderate depression, the psychosocial support is also needed. But that you could refer them with PSO, or, and I'm sure Gihan will have more. Gihan and Dr. Arambula might have more suggestions.
The second question is, I can give you suggestions later on. So, as you're working in the same hospital. So, the second question is, we come across a lot of women with, in the perimenopausal age, they come with vasomotor symptoms.
Yeah.
So, then we start them on escitalopram 10 milligrams or venlafaxine 37.5, sometimes 75 works. So next time when you see them, they see that there's a marked response, not only the vasomotor symptoms, like they overall they feel better. So is it because the element of depression has got treated there, or is it because of like this particular dose that we are giving?
What's the dose you've been using?
10 milligrams of paroxetine, and venlafaxine we generally give 37.5 or sometimes 75.
Yeah.
So is it depression which is really
because perimenopause, for a woman, depression hits the vulnerability to depression in the life course. It's most during the postpartum period, some during the antepartum, and also perimenopausal, and of course perimenstrual. So perimenopausal is a time, not sure, okay. Perimenopausal is a time where, so they might be getting not a severe depression, but there may be some depressive symptoms together with the physical symptoms. The doses you're using, escitalopram 10, venlafaxine 75, are therapeutic doses for depression. So it could be likely depression. I mean, there may have been some mild depression, which is getting corrected. You probably don't need to go to venlafaxine in that instance. The SSRIs they're just easier to manage, and they often do the job as a first line. Probably. Yeah.
Actually, one more question. In this very hall, as part of the KSM program, we had one coach coming here, and he was talking about how people who have these depressive symptoms, they talk to them over the phone, and they have this counseling program, and then he goes on asking questions, so then the person who is actually depressed realizes what is actually causing the depression. And then he was telling that if you straight away go to the psychiatrist, they give antidepressants, and then that changes the biochemical milieu of the brain, which cannot be reversed. So now these are people who are like they are involved in treating patients with depression. It's part of maybe cognitive behavioral therapy or whatever, I don't know. But these people telling things like this might give the wrong idea for people. I mean, even for medical professionals, because that particular lecture was for medical professionals.
Okay.
So therefore, I think you have to be careful about this mix also, which may be
Yeah.
spreading in society.
I think that's very true. Thank you. That is a
Comment,
yes.
Thilini, this is regarding then how the referral comes. So when you really want to send a patient, I think what I tell them is I'm not expert on that area. So what I tell you, I directly tell I'm expert on surgery, this aspect only. I'm not going to treat you for that condition which you are referring, but they may be better in treating and finding out the real ground situation of you. So then I won't treat. Full stop. Then I refer to the relevant person. So that works for me because when they accept that when they say I'm not an expert to treat that condition, they accept it.
Yeah.
Because we are very reluctant to tell that. That's what I feel.
Okay.
Because we want, we looks like it's something when we tell that it harms our personality. I mean, one thing is one shot, they finish everything and go, that is one our attitude of our patients.
Yeah.
I'm not hesitate to tell that I'm not expert, I'm not good enough to pick up your problems in that area. So it's very easy for me to, because it's a clear cut area in my treatment method. So in this type of patient, what you mentioned, Charles, I think it's very clearly I can tell. I know that you have an issue, but this issue can be handled by another person than me.
Yeah.
He's an expert on that area.
Most of the time it works because when they really have a problem
And they won't
identify
help.
when you talk it works. But in the meantime you find another group where it is marginal and they are stigmatized by the fact that sending
Yeah.
someone to a psychiatrist means that I have something really bad.
Yeah.
So then however much you try to explain it, it's very difficult. So
So
that
I
is the
think
scenario that I was talking about.
that's fine. I think, Charles, you can certainly treat like that. Yes.
Some of the GI diseases are connected to some neuropsychiatric components, especially Winter syndrome. And there's a thing called functional dyspepsia and visceral hypersensitivity syndrome. How is your experience? Do you have any idea about any studies? Do you have any studies? Those kind of patients are more prone to getting depression, is it part of depression? The IBS and the functional visceral hypersensitivity syndrome. What do you suggest? Because according to the treatment protocol, the European and the American protocol, there's a place for right?
Yeah.
And
Yeah.
even for bicyclic as well. But nobody knows the duration, then how long and when to refer. So I think going like so,
I yeah.
I like that. What is your opinion?
I mean, there's certainly a correlation between, say, IBS and anxiety, for example, and depression. But like you said, I'm also not. I don't think there is specific guidelines as to this amount of the treatment is needed for this period of time. Um, I can look it up for you if you like. Go and see whether I can find anything. Off the top of my head, I don't know of any specific recommendations.
How long can the treatment refer to
No hard and fast rules. Certainly, if you see risks, I would refer.
Sometimes I used to recommend psychiatric to very
Yeah.
depression, but yeah, but that's very it's sort of a gray area in
And it's tricky because they're often a mild depression with anxiety, and it's such a long time it's been going on for. Um, but I have, I can't, I don't know of any recommendations that say it should be treated with this for this amount of time, and I don't think that evidence is there. But I can look.
it's not available.
No, I don't think.
Thank you very
Thank
much,
you.
Dr. Thilini Rajapakse.